with Dr. Vishali Gupta, and whom you all know is doing wonderful work in the field of veterinary technology, and she is a professor at PGI and is known for her work all across the world. So may I request Vishali to start sharing her presentation. She will tell us about posterior uveitis. You see, thrust of all these talks in itis are what everyone should know and should not miss in his practice. The aim is not to enlighten you for all the aspects. Aim is that we should know this much minimum. Everybody should know this much minimum and should not miss once a patient comes. So over to you, Vishali. I'll stop sharing my screen.
Thank you, sir. It's a pleasure for me to be participating. You know, Dr. Lalit Verma always comes up with very interesting ideas, and I love this itis part of the whole thing. And wonderful to have panelists and see friends. It's hope I'm able to do justice to the topic. So what are the itis in posterior uveitis? We have retinitis. We have retinochoroiditis, which means that whenever retina is inflamed, the part of choroid would get involved, but the primary disease is retinitis. Then we similarly go on to choroiditis, where choroid is primarily involved. And then whenever choroid is involved, the overlying retina will be inflamed. So it becomes chorioretinitis, and finally vasculitis. So a beautiful question put by Dr. Verma was, what should not be missed? And I'm not talking here to the uveitis expert, I'm talking to all of us who happen to bump into these patients. There are 6 points. One is one should not be confusing between retinitis and choroiditis, and that is the crux of the whole thing. Do not confuse between non-itis and itis. Do not confuse between infective and non-infective itis. Do not miss masquerades by just labeling them as choroiditis, because that's a very convenient thing to do. And not to confuse between the complications of itis and the recurrence of the inflammation. And finally, if I have some time, I may talk briefly about pattern recognition in vasculitis. Now let's see the case examples. The first thing which I said was not to confuse between retinitis and choroiditis. Why? Because the moment you see retinitis, the chances of it being infective are quite high. How does retinitis present? It can be either focal or diffuse, and I'm going to show you examples of each. If it is focal, there are 2 main etiologies. I'm not talking of the rare things here. It can either be toxo or it can be Behçet's. If it is diffuse, for all likelihood, it is viral and very rarely toxo. So let's see this patient who comes to you. Now this is retinitis, and for the youngsters who are with us, you see it is fluffy white. You don't see blood vessels which are crossing it very clearly because it's a part of the retina which is inflamed. So when you look at this patch of retinitis, you may see overlying vitritis, and it may appear sometimes headlight in fog. The moment you see it, it is toxo. Many of you might have read in the book that toxo comes next to the congenital scar, and there is a satellite lesion, and there is all that stuff. But believe me, those are not common. Most of the time, toxo is acquired. So if you are seeing retinitis like this, which are the features that I have already mentioned, you may have fluid which is surrounding this lesion, but it is going to be creamy white, and the edges are not so well defined. You may do fluorescein just for the heck of it these days, I say. But what you see, if it is an active disease, you will have early hypo becoming gradually hyper, and you have a pocket of fluid. But to me, it's more important on OCT. As you can see, it's the retina which is involved, and you can see the choroid is not involved. What you are seeing is you are not seeing underlying choroid because the retina is inflamed. And of course, there are cells in the vitreous. And these days, vitreous cells are actually better seen on OCT than, clinically. So retinitis, I just mentioned. When I see retinitis, to me, it's either toxo or Behçet's. But this one is so classically toxo, and there is no vasculitis. So what do I do? Honestly, you can get IgG and M if you want, but it really doesn't alter the management. So if your clinical acumen is good, go ahead with the treatment, and this is what you end up with. We will not go into the details of the treatment, but you see the lesion responding very well to antitoxotherapy. This is, on the other hand, is another case, which again, if I show you, it's bilateral. You have these small patches of retinitis. They do not look like toxo because you don't have that headlight and fog. And there is something happening to the vessels in the periphery, to a fluorescein. A fluorescein here shows the leakage from the capillary. And please always keep this picture in mind. If you see, this is called fern tree pattern. So if you see these branches like the fern tree, this is always more than 95% chances of this being Behçet's. Though very rarely the other diseases like TB and all might show, but if this is in context to retinitis, it's invariably Behçet's. Ask the history of oral genital ulcers and other things to rule out Behçet's disease. So this was my point number one, that you got to differentiate retinitis from choroiditis. So many of you would come up with a very simple question, why the hell, why I need to know it is retinitis? And I will show you a case example. Now this is the patient. The first picture, what you are seeing is seen elsewhere, a big center, and it's labeled as choroiditis. But if you see it very clearly, this is very typical picture of toxoplasmosis. It is retinitis. It is retinitis. So if it is retinitis, it is retinitis. It got to be infective. You got to rule out toxo, but that was not done. Instead, intravitreal steroids was injected with the diagnosis of choroiditis. And see what happens. The middle picture is the one when we saw him. It's a diffuse disease which has progressed because somebody failed to just recognize the phenotype. You don't need complex investigation. You just need to look at the patient. And the last picture is after antitoxo treatment. Though we could heal the lesion, but there is no fun because we lost the fovea and the guy lost his central vision. After the retinitis, we come to the choroid, and when it is choroiditis, you can see it is deep, it is dull yellow, and you can see the overlying vessels very, very clearly. Now, choroid has a very, very specific way of showing the insult. It can either be focal, which can be unifocal or multifocal, or it can be diffuse. Now, suppose this patient comes to you and the picture on the left, you see it's deep-seated, it is unifocal, it is large, and you also see these small hemorrhages on top of it. If you see a granuloma like this is very classically of TB. Because when you see a granuloma in the choroid, there are two differentials, TB versus sarcoid. TB granulomas tend to be single, they tend to be more oval, and they tend to have these hemorrhages and CNVMs on top of them because TB is VEGF-driven disease. So you treat it and you will end up with a result like this. Another form of choroiditis, which in this country is everywhere, is serpiginous-like choroiditis, which is associated with TB. Now, this serpiginous-like choroiditis, you can identify because of its multifocality. You may have cells in the vitreous associated with it, and you may have some little bit of vasculitis. And this is the point I would like to show. The patches of choroiditis coming along the blood vessels, which is called perivascular chorioretinal patches. These are very highly typical sign that you may have an underlying TB. So please don't be, I mean, you have to give steroids, but test for TB, and those tests, if come positive, you will have to add anti-TB drugs to prevent multiple recurrences. And the picture on the left is the another patient which shows a diffuse variety of choroiditis, again due to tuberculosis. As I mentioned, that choroid has a very typical, because of its anatomy, which is the lobules. It will present either as focal or as diffuse variety, because focal is the each lobule involved, and when they become coalescent, they will form a diffuse like this. Choroiditis will not produce as a linear lesion because that's against the anatomy of the choroid. So we come to the second point, how not to confuse non-itis with itis. Now see the example of this patient. This patient has been diagnosed as TB choroiditis, received steroids, received ATT, has been deteriorating. But if you look at it, fair enough, this is not retinitis. But if you look at the morphology, this is not choroiditis as well. So what is it? This is something happening in the subretinal space, and this is fibrin. Before we go into this, I would just point out that if you see this dark spot in the center of the yellow lesion, think this is more of a fibrinous CSE and not choroiditis. So what do? We do the fluorescein, and what you see, the dots which are expanding. If it is choroiditis, it will be hypo in the early phase, becoming hyper in the late phase. If it is CSR, it is hyper in the late phase and becomes expansile and more expanding in the later phase. Only thing we have done is just to stop steroids, and you can see that after stopping steroids, the patient has responded very well to therapy. The question was, and many of you must be wondering, was it TB choroiditis to begin with, and after treating it became? So we asked the patient to get the angiogram when she was seen for the first time, and you can see that the first time she ever presented to the ophthalmologist, it was actually CSR, which was mistaken as choroiditis. But if you pay attention, this linear thing here and these dark spots, it cannot be choroiditis. So this is just another example of this patient has actually received IV methylpred, being diagnosed as VKH, but this is not VKH because this is not the fluorescein. And again, you see the fibrin deposits and you see this dark spot. The dark spot is because the fluid is leaking in CSR and it is displacing the fibrin. So these are some of the classical examples of non-itis being mistaken as itis. So if you're not sure, please do not be in a hurry to push in IV steroids and all, because you can do more harm than good. The third point is not to confuse between infective and non-infective itis. And this is just an example of diffuse retinitis. As I said, retinitis by and large are infective. So if you are seeing this diffuse variety of retinitis here in the periphery, and you start patient on steroids without thinking of viral as a possibility, you are going to create havoc, and actually havoc in both the eyes. So this is just what happens. The disease just progresses very quickly. Another example, how important it is not to mistake the two. Now this is a one-eyed patient. Let's start from the top. This patient was seen and was diagnosed as sympathetic ophthalmia because something is happening just close to the disc. Fair enough. Patient was not responding to very well to steroid. And look at the pattern. This is peripapillary choroiditis. This is not how sympathetic ophthalmia would present. So patient receives immunosuppression because not responding. Patient is progressing. If we go to the third picture, there is some occlusion and few cotton wool spots which are mistaken as toxo, and she receives anti-toxo. And this bottom is where we saw her for the first time. She's actually positive for TB, and the final picture is response to anti-TB and anti-VEGF, which we sometimes combine for the underlying new vessels. That's not the point. The point is, when you see here, it talks like a duck, walks like a duck, got to be duck. It's a choroiditis. It's a diffuse choroiditis, which has an edge. So even if it is one-eyed patient, even if you have trauma in the other eye, you got to rule out the common thing, which is tuberculosis, or maybe syphilis or something else. But you do not keep on pushing IV methylprednisolone because that poor lady had trauma to the opposite eye 20 years ago. So this is what I am emphasizing on, is to recognize the pattern. Again, an example. Now, I have already shown you choroiditis, and just I'm going passing with sometimes, I'm not going to talk about metastasis here, but some of these leukemias, lymphomas are very classically subretinal. Now, this child, he might be having fever, he might be having cough, he may be having lethargy, but this does not look like TB choroiditis for the simple reason it's not yellow. For the simple reason you can see these blood vessels running over this, they are dilated, and you can see that there is something which is happening very close to the retina. And this child actually was diagnosed as ALL, and this is how following the treatment for ALL. Always remember that whenever we see a posterior uveitis patient who's either too young or too old, the autoimmunity by and large gets tired when you are above 50. So always try to rule out masquerades and malignancies. This is another such example. You look at the pattern. This is not truly retinitis, neither is it choroiditis, because as I explained you, it doesn't fit in either. So what is it? Get a OCT done through the lesion, and OCT shows you beautiful elevation of the lumpy, bumpy, and subretinal deposits. So these subretinal deposits are very typically deposits of lymphoma. Don't miss. Get a autofluorescence done. You will see that leopard skin appearance. And these are the kind of the patients you probably would need to recognize and refer, because if you push in steroids, they will respond. Lymphomas respond. So you are not only delaying the onset of diagnosis in the eye, but you are actually delaying the onset of CNS lymphoma and even the life expectancy of the patient, I must say. My fifth point, do not please confuse between the complications of inflammation and the recurrence of inflammation. And this is what we are seeing now very commonly. This is a young girl who actually comes from Calcutta, and she is already on immunosuppression, received ATT, she's scarred, she's a smart girl. She says, I have metamorphopsia and I have been told to add another immunosuppressive drug. Okay. So I did not see any, to be very honest, any activity of the choroiditis, got the fluorescein. And if you look at the arrowhead, there was something happening. But believe me, this arrowhead I have put in retrospect. When I saw this fluorescein on Optos, I said, oh, there's nothing much happening. It all looks healed to me. So we do OCT angio, and we see this network of new vessels here. So they were there, and many of you will say, oh, they're just mature network, because all our understanding of new vessels come from AMD. But listen to the patient. So we did inject her, you can see on the top, and then you can see here is after 7 weeks, the new vessels did regress. And then we thought probably we do not know, let's wait. And 14 weeks later, you can see this increasing again, vision going down again. So I'm not saying that you monitor every patient, but what I'm saying is if you see at this stage and you are not able to figure out what is going on, just do not push in another immunosuppression because you think it is activation of the lesion. It may not be activation. Another example, this is CMV retinitis. We started him on treatment. He was responding, comes with decreased vision, and this time there is a small little hemorrhage. So please examine the patient very carefully because many a times these patients may be having something else which needs your attention other than simply the infection that you are seeing or the healed infection that you might have seen. My last 3 slides, if the time permits, I would talk about vasculitis. So what is vasculitis? Characterize, like you characterize retinitis, choroiditis, characterize vasculitis. Is it phlebitis? Is it arthritis? Or is it capillaritis? I have already shown you the example of capillaritis is Behçet's, phlebitis is mostly TB, sarcoid, arthritis is Irvan and Takayasu's, and we will not go into that detail. Again, try to recognize, is it focal, diffuse, and very importantly, does it have associated lesions like choroiditis, retinitis, because that will make a very important clue towards possible etiology. 2 of fluorescein, because you can see the condition like Behçet's, just based on the fluorescein you can diagnose. See any systemic association, shortlist your differential, targeted labs. I will not go into fluid analysis. Now, this is just an example of Behçet's again. So you see, there is vasculitis. This is again, the capillaries are leaking down here in the bottom slide. Ask patient to open mouth, oral ulcers, nothing else is required. Don't go in for extensive workup, just spend time on the character of the lesions and time on the patient. 2 clues for TB vasculitis. They tend to be occlusive in nature. So you will find the areas of capillary non-perfusion in the periphery. You may have associated neuroretinitis and choroiditis. If you're seeing these patches of choroiditis along with vasculitis and neuroretinitis, always examine the opposite eye, which may show you very characteristic healed perivascular lesions. So these are the signs which are very, very diagnostic for possible TB etiology. So I'm not going very extensively. I'm coming back to my original slide and I'll be happy to answer any questions. So what you should know. First, you should know what you are dealing with. Is it retinitis or is it choroiditis? Second, you should know if it's not choroiditis and it is not retinitis, is it really an itis or is it some funny variety of non-itis like CSR, fibrin, or something else which you are confusing with itis? And why is it important to know? It is important to know because the moment you diagnose CSR as TB or as VKH, you give steroids. So you cause the worsening of the primary disease a lot. So it's very important that if something is not fitting the bill, spend some time on the patient rather than just be in a hurry to inject. The third thing is not to confuse between infective and non-infective. That I showed you example of peripheral retinitis. If you think it could be even an iota of chance, it could be viral, don't ever think it would be non-infective. The fourth is if there is something happening in the subretinal space, and that too either in the children or in the adults or even in the youngsters, the subretinal space is not a place for usual uveitis. Rule out masquerades. Fifth is do not confuse with complications of itis because C and VMs are very extremely common simply because your patient is having a deterioration of vision and metamorphopsia Does not mean you need to add another drug to it because you think it is activation of uveitis. And believe me, I don't know about you, but I still find it very difficult to interpret my fluorescein angiography in the hula blau of all those scars and all. So one can easily miss CNVMs. You got to look out for them. So if the uveitis seems healed to you, just do not add another immunosuppression. Look back, think what it could be. And for vasculitis, just a pattern recognition would be good. Don't order everything from, you know, everybody. Thank you very much. And thank you once again for giving me an opportunity to be on this platform.